Thank you so much for having me here today and for inviting me to deliver this talk. So I'll be talking about COVID, vaccines, and hopefully telling you all how you've been a critical part of our research team over the past 2 years or so. So as we know, the COVID-19 pandemic, the scale of it has been huge, and the rate or the velocity at which it has continued to change over the past 2 years has been very rapid. There have been to date more than 529 million cases, more than 6 million deaths worldwide. And at the very beginning of the pandemic, it's an unusual situation in that we knew very little. And for research, it really is quite unusual to know next to nothing about something that is fast moving and emerging. And particularly for people with psoriasis, now we know that psoriasis is a common disease, it's prevalent all around the world, and it's immune mediated. And some of the immune proteins that we know are upregulated in the skin in psoriasis, such as, for example, TNF, were also being implicated in the immune mechanisms behind severe COVID. So what did that mean? Secondly, we know that psoriasis, as we've heard today, that it's associated with lots of long-term health conditions. And there was some data at the very beginning of the pandemic from a collaborative called the Open Safely Research Collaborative, and they collected data from more than 17 million individuals in the UK using healthcare record data. And the signal that came out from their study was that there are certain long-term health conditions such as obesity, as well as conditions like ischemic heart disease that may well increase the risk of poor outcomes from COVID. So again, what does that mean for people with psoriasis? And we treat moderate to severe psoriasis with drugs that affect the immune system. And that raises many more questions, both about severe COVID outcomes, but also about responses to the COVID vaccines. And of course, as we've heard, people who were deemed to have a weakened immune system, so people who are on these drugs that affect the immune system, as well as people with multiple long-term health conditions, were deemed at high risk of severe COVID. And the guidelines told those people to shield for large periods of the pandemic. And that had a huge impact on day-to-day activities. We know that psoriasis is associated with anxiety, depression, has a huge mental health burden, and it's been very well documented in the pandemic that the mental health burden of the general population has been substantial. So again, what does that mean for people with psoriasis? So many, many questions, and questions that continue to evolve as the pandemic progressed. There were 3 key research aims that we set out to address. Number 1, at the beginning, was to characterize the course of COVID in people with psoriasis and to identify the factors that were associated with severe COVID. Second, we wanted to really understand the experiences of people with psoriasis in the pandemic in order to inform the clinical care that we were delivering every day. And then thirdly, with this huge breakthrough of the COVID vaccine being introduced and rolled out, well, what does that mean if you have a weakened immune system and are taking drugs that affect the immune system? Does that then mean that you also have an impaired response to the vaccine? So that's the third question. And this was our research timeline. So we launched PsoProtect and PsoProtect Me, which are 2 research registries I'm going to briefly tell you about, in March 2020, and then PsoProtect Me was launched in May 2020. And then shortly after the vaccine rollout commenced in the UK, we launched our vaccine study in January 2021. So first to PsoProtect. So PsoProtect is an online registry for doctors, nurses, any clinician to report any patient who's under their care that has confirmed or suspected COVID, and to tell us about all of the clinical features. Were they unwell with it? What other medical conditions did they have? What drugs were they taking? It was a very simple 5-minute case report form that anyone, any clinician across the world could access through our website by just clicking that little red button at the top. And we launched a sister registry for individuals with psoriasis to tell us about themselves. And this was called PsoProtect Me. And we launched PsoProtect Me in May 2020, as I said. And again, this is an open access website. Anyone around the world can access it. And we ask and continue to ask anybody who has got psoriasis to tell us how they're feeling through this web portal. It's available in 9 different languages. And thanks to the phenomenal support that we've received from patient organisations, professional organisations, and in particular the Psoriasis Association, these efforts, both PsoProtect Me and PsoProtect, have been truly global. We also aligned ourselves with partner registries. So we were asking these questions about psoriasis, but there were other research teams asking the same questions about psoriatic arthritis, inflammatory bowel disease. So we collaborated with them from very early on, and in particular linked up with the Global Rheumatology Alliance and made sure that the questions that we were asking were aligned with the benefits, that then we could pool our data across diseases to increase the power to try and come to conclusions from our analyses, and look for patterns across diseases. And then that's Secure IBD in inflammatory bowel disease, and then Core UK is a UK-based rheumatology registry. And so this is the data that we have had in so far. So in PsoProtect, which is the clinician-reported registry, we've had just over 1,500 cases reported, and you can see the spread there. So it's mostly across Europe, UK, Spain, Italy, France, but some reports from South America and US too. And then PsoProtect Me, we've had around 50% of our reports from the UK, and then a nice global spread for the remaining 50% across Asia, North America, South America, and across Europe. And in total, we've had more than 5,100 people with psoriasis report through PsoProtect Me to date. So what has all of this information told us? So I'm just going to take you through this first research question in the first instance. So one thing that was clear, the data came in very quickly. So by doing this online registry, we were able to collect a lot of data in a short space of time, so much so that by the early autumn, we were able to publish our first paper describing COVID outcomes in people with psoriasis. We recently updated our analysis at the end of last year, when our data set had expanded to 1,200, and actually all of the findings were still holding true, despite substantial time that had passed. So the first key finding, which was very reassuring at the time when we didn't know much, is that more than 90% of cases that had been reported to PsoProtect showed that the patients had fully recovered from COVID without any complications. And this is in the context of the majority of patients being reported had received some form of drug that affect the immune system. So 70% were on biologics and 17% were on non-biologics. So that was important. And then we started looking for the risk factors. So what would make somebody more likely to get hospitalized for COVID? And it looked like for people with psoriasis, it was the very same risk factors that were being shown in the general population. So the key risk factors for hospitalization were being of male sex, older age, non-white ethnicity, and then these other health conditions. So high blood pressure came out, chronic lung disease, liver disease, heart disease. When we looked into medications, we found that non-biologic immunosuppressants were associated with increased risk of hospitalization compared with biologics. And this was also something that was seen in our partner registries, so in the rheumatology one and in the inflammatory bowel disease one. However, it's very important to consider the limitations of registry data. And certainly when we were writing this up, when we were discussing the results at our communications teams meetings, this was at the forefront of what we were thinking. So the key thing is these are observations, and observations are not causal. So there may be other unmeasured factors that, for example, may be associated with biologics use that could be causing this signal. And one of those is shielding, and I'll come to that very shortly. Then there's also always selection bias to consider when you're doing research. And one thing that was clear is that our data set's dominated by patients taking biologics. And also, clinicians may have been more likely to report their severest COVID cases, so may not have known about, so for example, most of the clinicians reporting were hospital clinicians, so perhaps they hadn't known about their patients who had perhaps had milder COVID. That's a possibility. And of course, in the grand context of the huge scale of the pandemic, this is a limited sized data set. So it's important to consider that when thinking about how generalizable the findings are. So we wanted to drill down more into this signal about the differences in risk of hospitalization between different drug groups. And we turned to PsoProtect Me. And as I mentioned before, the key aim of PsoProtect Me is to understand the experiences of people with psoriasis living in the pandemic. So we first looked at risk mitigating behaviours, so shielding behaviours. And one thing that we saw was that shielding seemed to be more common in people taking biologics compared to those taking either non-biologics or standard systemics, or those on no systemic treatment. So one possibility is it could be that this greater shielding behavior or risk mitigating behavior among those on biologics may well be contributing to the reported lower risk of severe COVID. So actually turning to the patient experiences was very informative in interpreting the clinician reported data. We also used PsoProtect Me to understand the burden of the pandemic on individuals with psoriasis. And we asked a very simple question about what happened to people's psoriasis during the pandemic. And 43% of people reporting to PsoProtect Me, and we did this analysis when we had just more than 4,000 total participants, 43% had reported that their psoriasis had worsened in the pandemic. We tried to drill down in what could be the factors at play there, and self-reported worsening of psoriasis was associated with a positive screen for anxiety and depression. And within the PsoProtect Me dataset, we had embedded a screening tool for both anxiety and depression. And you can also see that the blue chart on the far right there, that's a symbol that depicts not taking medication anymore. And actually 18% of participants reporting to PsoProtect Me said that they had either delayed or completely stopped their medication during the pandemic. And the top reason for that was being concerned about complications from COVID. And sure enough, as the blue column shows, delaying or stopping medication was associated with worsening psoriasis. And actually, those who did delay or stop their medication, they also more commonly screened positive for depression and anxiety compared to those who continued treatment. So this data, which we published and fed back to patient professional organizations, fed back to clinicians, really highlighted the huge burden of the pandemic on individuals with psoriasis globally. This data came in from more than sort of 70 plus countries. And also the importance of mental health screening and mental health support embedded within ideally dermatology core services. And then now I'm just going to talk about the vaccine. So the final aim was to understand if people with psoriasis who are taking drugs that affect the immune system, whether they have impaired immune responses to the COVID vaccine. So it was a huge breakthrough, the COVID vaccine, and this is just briefly how it works. So the vaccine prompts the immune system to produce both antibodies and T cells in order to destroy COVID-infected cells. So then, if the same individual who's vaccinated encounters the SARS-CoV-2 virus, then those T cells and antibodies that are primed are then triggered to fight the virus. And that there is a snapshot from Guy's Hospital from our own vaccination centre. But this was a huge effort, not just in the UK, around the world. And as you'll remember, the rollout was in stages, and the stages were were stratified by age. But you'll see there that there is the category alongside 70-year-olds, which is clinically extremely vulnerable individuals. So individuals receiving drugs that affect the immune system were prioritized for the vaccine. But a key question was, is the vaccine as protective for people who are receiving drugs that affect the immune system? So we undertook two studies back to back, where we took a group of individuals with psoriasis who were our patients at Guy's Hospital, and a group of healthy controls who didn't have psoriasis and were not taking drugs that affect the immune system. We looked at their blood tests before they received the first dose of the vaccine. We looked again at their blood tests in order to look at both the antibody and T cell immune responses they were mounting. We looked after the first dose of the vaccine, and then again after the second dose of the vaccine. And this is one bit of interesting data that came out from our analysis after the second dose of the vaccine. So if I just take you through this, and in particular, if you just look at the control group, which in that chart is the one on the left. So you'll see after the first dose of the vaccine, there's a proportion of that control group who have not mounted a detectable T cell response. So the response threshold is the horizontal dotted line, and there are 5 dots or so that are below that line, the blue ones. After the second dose, everybody has mounted a detectable T cell response. So that's our controls. And then we have 4 groups of patients who were taking a drug that affects the immune system, whether that's methotrexate or a type of biologic. And if you look at all of those groups, they have something in common, and that is after the second dose of the vaccine, there is still a proportion of individuals who have not mounted a detectable T cell response. So they've not gone above the threshold, they're still below it. So that's important and really contrasts our control group. So in fact, 29%, if you take all of those treatment groups together, 29% of those individuals who were taking an immunosuppressant drug had no evidence of a T cell response. And the T cell response is important in driving memory B cell responses. And that is something that's important in driving a long-term antibody response to the virus. So in somebody who has not mounted an adequate T cell response after the second dose of the vaccine, they may not have durable protection to COVID at that stage. So this data really cemented the need for a subsequent dose of the vaccine. And this data we released very quickly in order to feed back this finding. So the vaccine is important. Having all of the doses in the course is important. But what do people who we're asking to have the vaccine think about it? So we turned back to PsoProtect Me, and we asked some questions about vaccine hesitancy. And actually what we found was very reassuring, that only a small proportion of individuals, so only a minority, 8%, decline the vaccine, or reported that they declined it. And the majority of respondents had received at least one dose of the vaccine. When we updated the questionnaire in early 2021 to include vaccine questions, we also introduced questions about access to care. And it's quite striking that 40% of people who responded through PsoProtect Me reported disrupted access to their psoriasis care during the pandemic. And when we look at who is more likely to be vaccine hesitant, we found that individuals who were vaccine hesitant were more likely to be younger, be of non-white ethnicity, live outside the UK, and have lived with psoriasis for a shorter amount of time, not be taking a systemic immunosuppressant, and importantly, have experienced disrupted access to care. So again, we fed this data back to really underscore the importance of being able to access communication with their clinicians, to inform clinicians that, this is the landscape of the difficulty of accessing care, to hope that we were able to improve and move forward services. A large part of this work, because it has been moving very quickly, a key part has been feeding it back just as quickly. So bringing in the data, analysing it, and feeding it back to complete the cycle. And our data, both from PsoProtect Me, and also from the vaccine study, has informed policy both in the UK and internationally. You can see here two examples at the top. So the National Psoriasis Foundation is based in the US, and the International Psoriasis Council is also, the headquarters are in the US. The guideline documents that they released to inform clinical practice were based on some of the data coming out of our studies, and also guidelines closer to home here from NICE in the UK. Our vaccine data was cited by the Green Book. So the Green Book is the key resource for UK clinicians with respect to vaccinations. And when during the pandemic, Chapter 14 was added to the Green Book because of SARS-CoV-2, and this led to a new piece of work and a new set of guidelines. And our data is quoted as underscoring the importance of a complete course of vaccine doses, because these drugs can affect vaccine responses. We have produced a series of infographics in order to summarize the data. Each paper that we've put out, we have published an aligned infographic with the help of the Psoriasis Association, IFPA, and others in our communications team. And this has been a really useful exercise for actually us as researchers to distill down sort of quite long and complex analysis plans and outcomes into key headlines and key headlines to inform clinical practice. So this is an important exercise, and this is something that we as a research team will continue to do for all of our projects. We have done a number of videos and podcasts, webinars, in order to feed back our data to patients, the public, and also clinicians over in the UK and beyond. We've been active on social media and led on writing press releases, newsletters, and blogs. If you'd like to see more of our data, please go to our current data pages. So we have one on the PsoProtect website, and we also have one on the PsoProtect Me website. And here it's as the cases come in, our numbers, our number counter goes up, so you can almost see it in real time. And also there's summaries of the data. There are also links to all of our papers and our lay summaries there too. So we've learned a lot over the past 2 years, and PsoProtect Me and PsoProtect remain open, and we are very keen to continue to collect data, and we'll be updating the fields that we collect as the research questions change, as we've been doing. We will also be leveraging everything that we've learned to develop BSTOP. So BSTOP is a study that is run by Catherine Smith at Guy's and St Thomas's Hospital, and it has been going for more than 10 years. And what we have learned is the power of having a self-report platform such as PsoProtect Me. So going to patients and asking you to fill in the data to help us to learn. So one key update for BSTOP will be to launch a self-report platform. And what we'll be trying to understand with BSTOP is how lifestyle factors can influence psoriasis severity and remission, and understand more about the underpinning molecular mechanisms, with the ultimate aim to lead to new strategies for effective management. We're increasing the scope of BSTOP so that all individuals with psoriasis can be involved, similar to PsoProtect Me. And the idea is that real-time, regular self-reported information will come in on the environment, lifestyle, and severity. We've also, through PsoProtect Me, learned that we can incorporate photographs, and this is something that we have used PsoProtect Me for at St John's, at Guy's and St Thomas's Hospital. And we have also been collecting e-consent from patients reporting PsoProtect Me so that we can link the data that they give us and the information to the wealth of information that's in patient health records. So that's something we'll be doing. And the final thing, in order to get these mechanistic insights, is through blood samples, but trying to improve accessibility, we'll be looking at trying to see if we can get blood samples done at home and then sent to us to avoid having to come into hospital to get research blood tests done. So this is all in the pipeline, and thanks to the funding from the Psoriasis Association, it's a very exciting time to be able to take these plans forward, and we'll be launching later in the year. So I'd just like to finish by really thanking the huge team that is behind everything that you've heard today. So PsoProtect and PsoProtect Me is led by myself and Catherine Smith, and Jonathan Barker and Chris Griffiths are on the executive committee. And it's been our huge pleasure to work with fantastic colleagues nationally and internationally, from basic scientists to epidemiologists, and also all of our patient advocates. I have to thank our fantastic communications team. So they have really inspired us to do better with how we present our data, how we understand it in the patient's eyes. So I'm incredibly grateful to Dom, Amber, Camille at IFPA, and Jade and other colleagues for meeting on a weekly basis and keeping us on track. And finally, I'd like to thank all of our patients, so all of you here today listening at home. Thank you so much for sharing all of your experiences. Thank you for helping us to learn from you, because this research has really been directed by you. So thank you for inspiring us to keep asking questions, keep collecting data, and keep doing better. And we look forward to doing lots more in the months, years ahead. Thank you.